So we will start at 11:15, right? Shall we wait for 4 minutes more?
Okay.
May Dakshit, do you have my number? WhatsApp number?
I think so.
Machan, can you put a message? I will send a PDF.
Okay. Give me a minute.
Okay.
My phone. I sent you a message.
Okay, Machan, wait. I sent already. I think 2 people, right? I think Chamar Nirmal is recording. So Charuk and Dakshit, right?
Yeah.
Is it?
Dinadvaya and me.
Hari, okay. So Machan, so we will discuss. So less people, we can freely discuss. And this is not like a bet. You can ask any question. And I will also ask a question. Like, we will make it as a long case. Okay. So I have sent several cases. We will discuss those cases. Is it okay?
Okay, Machan. Sure. Okay.
Okay. Right, Machan. So, Machan, can you read the first question? So the first case is for you. This is just for discussion, right? Okay. Yes, Machan. So let's start with the first case. Did you get that PDF?
I put it into the group. Yeah.
Okay. Right. Okay. So, Machan, the first question is: 20-year-old male presents with frothy urine and periorbital edema. On examination, there is periorbital edema and mild angle edema. Blood pressure is normal. UFR shows protein 3+. So, Dakshit, so what do you think about this case?
Proteurine, periorbital edema, and mild ankle edema.
Right.
So 20-year-old male patient.
Okay.
Yeah, it's protein 3+. So it should be renal in nature because there is periorbital edema and protein 3+ in the UFR.
Okay, but excellent. So, commonly in our long case, how do we get these nephrotic and nephritic cases? Because the patient usually present with generalized edema, right? Gross edema.
Yeah.
Okay. So, in our history, so this is for an example, I will present a sample history. So, this is a 20-year-old male, previously perfectly alright man, now has presented with, let's say, generalized edema for 2 weeks of duration. So 2 weeks back, he was apparently well. Since 2 weeks, he has noticed there was a mild puffiness around the area, and it was pronounced more in the morning time, and over a period of time, it came to normal. And next day that he felt the tightness in the dress. So this is how the history will go. So in our history, first, usually patient presents with edema, no? So first we have to describe the edema, right? Okay. So when you are describing the edema, the examiner will surely ask a question. Okay. Why? Usually, in our differential diagnosis, when a patient presents with such as edema, in our differential diagnosis, we have several things. One is renal pathology. Number 2 is cardiac pathology. Number 3 is liver pathology. Number 4 is gastrointestinal pathology. It means low protein. chronic diarrhea. Okay. So in here, how we are going to differentiate commonly renal pathology and headache pathology is renal pathology usually patient presents with puffiness matter. So there is a reason. Why do they present with puffiness? Do you have any idea? Usually, if you observe heart failure, they don't present with puffiness, no, but the nephrotic syndrome patient presents with puffiness. What is the reason?
Because mainly nephrotic patient occur that edema occurs due to low protein.
Okay.
Due to that, that fluid comes into the tissue in like a equal fashion.
Okay.
Not that in the cardiac one that it's due to the poor venous return and heart cannot pump real and the poor venous return. So there is accumulation of fluid in the dependent areas.
Okay, right, Matt. You are right. Can I improve your answer more?
Yeah, sure.
Okay, right. So, in the edema method, there are commonly two type of mechanism. Number one mechanism is reduced oncotic pressure, right? That is the case in the nephrotic syndrome, right? Reduce because there is a protein leakage, so reduce oncotic pressure. Other mechanism is increase hydrostatic pressure. That is the case in the nephritic syndrome and heart pathology, heartache pathology. Okay, in nephrotic syndrome, I will discuss later on difference between nephritic and nephrotic. In the nephrotic syndrome, there is a protein leakage. So the reduced oncotic pressure does not produce pulmonary edema. Have you got this point?
Yeah.
So reduce the edema due to reduced oncotic pressure doesn't produce pulmonary edema. So so they are lying on the flat position because there is no pulmonary edema. No, say they don't develop the shortness of breath, so they can easily lie down in the flat position. So their dependent part is this periorbital part is the dependent part, and same time the periorbital part there is a lot of lax tissue. There are a lot of tissue space, so the fluid collects in those space and they develop puffiness. But if the edema is due to increased hydrostatic pressure, they develop pulmonary hypertension. So they can't lie down in the flat position because they develop shortness of breath. So they have to lie down on the pillows, like they are in the proper position. They only sleep in the proper position. So this periorbital part is not their dependent part. So they don't develop periorbital edema. Have you got this is a famous question. Have you got the answer?
So one type of edema is due to increase hydrostatic pressure, other is due to reduced oncotic pressure.
In oncotic pressure, if reduced oncotic pressure doesn't produce pulmonary edema, that is the case, right? Doesn't produce pulmonary edema. So not this point. Machan, but not reduced oncotic pressure produces pleural effusion. Harida, reduced oncotic pressure. For an example, nephrotic patient, they develop pleural effusion, but they don't develop pulmonary edema. Have you got the difference? They develop pleural effusion. Both are different, right? They develop pleural effusion, but they don't develop pulmonary edema. Right. So this is the case, right? So this is how your history will be going. I don't spend much time on the history because we will be spending more time on the management. Okay. Harim Machan, now see, now our case is nephrotic syndrome, no? Nephrotic and nephritic syndrome. It means glomerular pathology, right? Glomerular pathology patients, please note, I didn't type anything. Are you noticing me? Are you writing down, Machan?
Yeah.
Important point. Okay. Right. So note this point. This glomerular pathology have several various presentations. Number one presentation is nephrotic syndrome. Number two presentation is nephritic syndrome. Number three presentation is rapidly progressive glomerular nephritis. It means they suddenly develop into acute kidney failure. That's number third presentation. Number four presentation is mixed features. There are mixed features, nephrotic and nephritic mixed feature, right? Number five presentation is CKD. Like for an example, over a period of time, they may not develop this nephritic and nephrotic features, but they gradually moving towards the CKD. That is number 5 presentation. Number 6 presentation is just asymptomatic proteinuria. They are leaking protein, but they don't have any symptoms. So this glomerular pathology have various presentation: nephrotic syndrome, nephritic syndrome, rapidly progressive glomerular nephritis, CKD, and last one is asymptomatic proteinuria. Have you got this point?
Yeah.
Is it clear?
Yeah.
Right. Okay. So our first cases discuss about nephrotic syndrome. Harida. Our first case discuss about nephrotic syndrome. Right. I am going to tell several points. Why this is nephrotic syndrome? Because nephrotic syndrome has 4 main features. Right? Taksi, can you tell me 4 main features of nephrotic syndrome?
There is hypoalbuminemia.
Machan, hypoalbuminemia correct, but first tell there are machan 2 important features. You have to tell that first. Edema, right?
Edema.
Excellent. Edema and proteinuria.
Then proteinuria.
Second one is proteinuria. Why I'm insisting these 2, because this is the essential criteria. Proteinuria, edema and proteinuria should be there to diagnose it as a nephrotic syndrome.
Okay.
Now tell the other 2.
And hypoalbuminemia and hypercholesterolemia.
Yeah, hypoalbuminemia, hypercholesterol. Excellent. You are right, Bachan. Now I am going to further asking several questions. The essential criteria is, right, edema and proteinuria. If the patient presents with edema and proteinuria, that is a nephrotic syndrome, even though if there is not hypoalbuminemia and hypercholesterolemia. Have you got this point?
Yeah.
Because they are not essential to diagnose. Okay, Macha. So, what is the most likely diagnosis here? Nephrotic syndrome, because they are a feature. Okay, Macha. Now note this point. This is very important point. There are 3 types of diagnosis in nephrotic syndrome. There are 3 types of diagnosis in nephrotic syndrome. Usually in our long case, we are giving, that is a clinical diagnosis. There are 3 types of diagnosis. Number 1 is clinical diagnosis. Number 2 is pathological diagnosis. Number 4 is etiological diagnosis. The clinical diagnosis means what we are observing. For an example, this patient has presented with edema and patient complains proteinuria. So there's a clinical component, right? All right. So it should be nephrotic syndrome. But now we are clueless because we don't know what is the histopathology. There are a lot of types, no? It could be membranous, it could be focal segmental glomerular sclerosis, or it could be minimal changes. We are clueless. Then why we are saying this is nephrotic? Because that is a clinical diagnosis. Just nephrotic syndrome is one of the component of diagnosis, right? But we can't stop here. We have to evaluate more, right? Now we have to find out what histological type this is, and now we have to find what has caused this. What is the etiology? Have you got this point, Machan?
Yeah.
There are 3 types. Okay. So what we are going to do is, in the pediatric population, to diagnose histopathology, we have to do renal biopsy. But not always we don't do renal biopsy because there is a reason. In the pediatric pathology, in the pediatric group, if they present with nephrotic syndrome, most of the time they are minimal change. So that is obvious. That is the reason we don't do biopsy in the pediatric group. Or else we should do biopsy. Because one diagnosis should fulfill these 3 components. But why don't we do the biopsy in the pediatric population? Because that is obvious. Most of the patient presents with minimal change. But in the adults, for an example, this case, this 20-year man presents with features of nephrotic syndrome. Why? But now we don't know the histopathology. Now what we have to do, Machan?
They have to do a biopsy.
Yes, we have to do the biopsy to this patient. Okay? But for an example, a 60-80-year-old patient with a diabetes mellitus now has presented with a proteinuria. Do we need to do biopsy, Machan, here?
No.
Why?
Because it's most likely due to diabetes.
Yes, diabetes, no. Whatever the histopathology it would be, we don't need to worry about it. Okay. So that's why we don't do biopsy in the diabetes patient. But this is a very young person, so we have to do definitely we have to do the biopsy. Right, all right. Okay, and now etiological diagnosis. For an example, there are a lot of etiology, right? There are okay. The etiology we can divide into two classes. Okay, one is etiology, primary. Primary means there is no causes. There is no causes, but for some reason, this kidney has developed some changes. For an example, just idiopathic minimal changes. Primary membranous, primary focal segmental glomerulosclerosis. There is no causes. There is no diabetes. There is no SLE. There is no hepatitis B. But the patient has presented with focal segmental glomerulosclerosis. We have done a biopsy. Now we have confirmed this is focal segmental glomerulosclerosis, but we couldn't find any etiology. So that is primary. Primary. So number one etiology is primary. And other one is secondary. Secondary means these changes has occurred due to several etiology. For an example, some infection, hepatitis infection, malaria infection, right? And HIV infection, several malignancy, lung malignancy, lymphoma, all right? Several autoimmune disease, SLE, okay? So that's due to secondary etiology, secondary. Do I have to repeat this?
In primary, the main histopathological diagnosis is we talk about this minimal change, focal. These are only come under primary.
Yeah, no, Machan. Even Machan, for an example, focal segmental glomerulosclerosis, it could be due to even SLE. Haridhar, it could be due to even SLE. But now we have done the biopsy. The biopsy says this is focal segmental glomerulosclerosis, but we couldn't find any etiology. We couldn't find any etiology. In that case only, it comes as idiopathic, primary. Haridhar. Have you got the point, Machan? Yeah, focal segmental glomerulosclerosis doesn't mean that is primary. That is a histopathology type, no?
Yeah.
I already told there are 3 diagnosis features, no? Clinical, histopathological. In the histopathological, now we have to find the cause. If we can't find any cause, we say it as a primary. If we are able to find any causes, we are saying we have to relate that cause. This focal segmental glomerulosclerosis nephrotic syndrome is due to SLE. Right? If we can't find any causes, this focal segmental glomerulosclerosis is due to primary. It means we can't find any etiology. Now, are you clear, Macha?
Yeah.
Are you sure?
Yeah.
Okay. So that is how much we have to give the diagnosis. But you don't need to worry about it in the exam, because in the exam, we don't know about histopathology. We don't know about the causes, no? Right?
Yeah.
So in the exam now, we are just giving the diagnosis as okay, this is nephrotic syndrome. That's it. But if we can, in the history, if we are able to elicit any etiology, you relate it. For an example, diabetes. For an example, you make it SLE. So in that case, you relate it. This nephrotic syndrome, most probable underlying cause is SLE. But anyway, I have to confirm the histopathological diagnosis with renal biopsy. That is how you have to give the diagnosis. Are you clear?
Yes, Machan. Yeah.
Right, Machan. Now, what is the second question here?
What is the most likely underlying cause?
Underlying cause, now we have discussed, no?
Okay. How would you confirm?
Right, Machan. Now in the exam, they are asking, okay, how you are going to investigate this patient? Can you tell me the answer as you are giving the long case?
How do you confirm?
Not confirm. How you are going to investigate this patient?
First, I have to confirm clinically. I have confirmed that this patient has edema. So then I have to confirm that this patient is having proteinuria.
Excellent.
So I can do a UFR or protein albumin creatinine ratio test for diagnose confirm proteinuria and
Yeah, okay. Stop,
quantify
Machan.
it.
Right. You are right. You are right. Machan, UFR, initially in the ward, we are doing UFR, no? But
Yeah.
that is not very sensitive, no? So, what is a very sensitive diagnosis? But there are two ways. Now, you can measure 24 hours protein excretion.
Yeah.
But that is practically very difficult, no? So,
Yeah.
then what is the best investigation?
The albumin creatinine ratio.
UPCR, no? Urine protein creatinine ratio. That is the best. Excellent. You are right. Now, you go on, madam. Go on. You are right.
Then for the supportively, I can check the albumin levels and the lipid profile in this child.
Excellent. That is the answer. So now you don't stop there. Now you have just confirmed. Sir, so in my investigation, I have several principles. I have to confirm the diagnosis first clinically, and then I have to find out any complications by doing several investigation, and I have to find out etiology, and finally, if needs, I will go with renal biopsy. Okay. Now you have mentioned to confirm diagnosis. Now, could you tell me are you going to do any investigation to find out any complication? What about serum creatinine, Macha? Serum creatinine, serum electrolyte?
Yeah, I have to do because the kidney function.
Okay, excellent. But not the point. Commonly in nephrotic syndrome, serum creatinine level is normal, usually normal. But in nephritic syndrome, that is mildly elevated. And same time, RPGN, rapidly proliferative glomerulonephritis, that is very much elevated. Usually in the nephrotic syndrome, serum creatinine level is normal. But still we have to do, no? Yeah. Still we have to do. Right. So to find out complication, and you have to do serum electrolyte also. And you have to do several investigations to find out etiology. What will you do?
To find out etiology, since this is a 20-year-old patient.
Yeah, excellent. You have to always relate with the patient, no? Okay, right.
Since
right,
this is a 20-year-old patient, but he is male. Still it can be autoimmune cause.
Okay, yeah. Still possible, no? Then you are right. Male patient, what we have to do, Machan? Better to exclude this hepatitis B and C HIV, no?
Yeah.
First, okay, you are right. Go on. What else?
Then it can be malignancy also young.
Okay, malignancy, commonly lymphoma possible, no? Lymphoma. So better to do this ESR, neither.
Yeah.
Okay, ESR, right? Okay, and C3, C4 level, complement level, and what else? And better to do fasting blood sugar, neither, no?
Yeah.
Okay, better, yeah. Okay, and this ANA double standard DNA also we can do.
Yeah.
Right. Okay. Then what is the final investigation? No.
Final investigation is renal biopsy.
Excellent. Renal biopsy. That's it. Right. So renal biopsy, you should know how you have to prepare for renal biopsy. No, first you have to get the concern, and you have to do several investigations such as PTINR because there's a bleeding risk. And very much important, you have to do the ultrasound scan because before doing renal biopsy, both kidneys should be healthy.
Yeah.
Because if one kidney has already gone, if you do the biopsy to the other kidney, there's a chance to go end-stage renal failure, end-stage CKD. So you have to do the ultrasound scan, and then you have to advise the patient, and how to do renal biopsy. Okay, so that's it. So this is how you are going to investigate. Are you clear, Machan?
Yeah.
Okay. Right. Hari. Okay. Right. Okay. Now let's move to the management. Hari.
Okay,
Machan. Dakshit. Okay. Now you are going to give your answer to the longest. Okay. And now sir, ask how you are going to manage the patient. What will you say?
So I have diagnosed this patient with
Or let's say this is idiopathy. You couldn't find any etiology. This is idiopathy. Now, how you are going to manage?
My mainstay of management is steroids, oral steroids. I will start oral steroids.
No, Machan, no, Machan. I think I have to help because you are starting is wrong. Not wrong. I think you better to improve. I already told Machan, always start with the principle. Don't jump into drug. Harida, always start with the principle. Right? So the management of nephrotic syndrome has two main principles. One is Machan, general management. Right? General management. Other management is a specific management, Machan. So we have to do a lot of things generally, what you will do generally. Now this patient with generalized edema on the bed. Now as a HO, what you are going to do generally?
I have to look for I think
for an example, every ward round, what will you do? What you have to measure?
I have to measure the input and output.
Excellent. Input output. So okay, that is the answer. Excellent. Input output. Okay, Dakshit, I am going to ask you a question. For an example, this patient's the output has reduced. What type of AKI is that?
Output reduced.
Yes.
It is due to reduced perfusion to the.
Excellent. There is a pre-renal AKI,
Yeah.
Why do they develop pre-renal AKI?
Because due to the loss of protein, the fluid will be going to the extracellular.
Right, you are right. Yes, you are right. So that is the answer. Yeah, you are right. Yes. So that is an intravascular fluid is compromised, no? Right. Okay. So that's a pre-renal AKI. So we have to maintain input and output. So we have to adjust it. All right. Okay. And what else? Do you have to measure weight, Machan?
Yeah, I have to measure weight, abdominal girth.
Okay. Abdominal girth. Okay, you are right. All right.
And have to maintain a chart of the.
Right. You are right, Machan. Okay. Do you have to maintain fever chart?
Yeah.
Why?
Because these patients are prone to infections.
Excellent. They are very prone to develop infection, no? So, Machan, now see, you can tell a lot of answer before starting steroid, because if you straightly start steroid, they will start to ask the doses and you will be in the trouble, neither.
Yeah.
Now you see, Machan, if you start with a general management, you can talk a lot of things. Right? Okay. Right. Now you are doing, and same time you have to measure the blood pressure, right? Right. Blood pressure. Okay.
In adult patients, do we do the things like urine water test?
Urine water, yes, madam. We are doing urine water, but in the adult patient, madam, usually we do the UFR, neither.
Yeah.
I didn't see these waters. We are doing the UFR mainly. Okay. Now, Machan, this patient, nephrotic syndrome. Now, in the third day, you are doing a ward round. Now, this patient has developed hematuria, and same time, patient has complained abdominal pain also. What will you do? What do you suspect?
Abdominal pain, I will examine the patient. If there is guarding and rigidity also.
Okay.
Secondary bacterial peritonitis.
But if secondary bacterial infection, then why do they develop hematuria? Unlikely, no?
Yeah.
So, is there any connection between hematuria and abdominal pain?
Infection, urinary tract.
No, still infection, they don't develop hematuria much, no? Have you heard about renal vein thrombosis?
Yeah, renal vein thrombosis.
So that is the answer. So what will you do, Machan?
Why they get renal vein thrombosis here?
Yes. Okay. Right. So this nephrotic syndrome patient, as you already told, they are more prone to develop infection. As like they are more prone to develop thrombosis also. Because there is a reason. They are losing the protein, machan. They are losing the protein, right? And they are losing more and more antithrombin 3. They are losing more and more antithrombin 3, right? There is a one reason. And second reason, they are losing more albumin to compensate that liver produces more anticoagulant. Sorry, liver produces more coagulant factor because this patient, they lose more protein. To compensate that protein, liver produces more coagulation factor. Coagulation factors are also protein.
Yeah.
So they are more prone to develop thrombosis, right? So they develop renal vein thrombosis. That is a very, very dangerous problem. So that is why this question is very important. Are you clear now?
Yeah.
So now, you have to do ultrasound scan to confirm. Right, to confirm renal vein thrombosis. So, Machan, this as the renal vein thrombosis, they may develop thrombosis anywhere. No? So, in your management, in your general management, you have to include that also. So, how will you prevent thrombosis?
We have to give prophylaxis.
Excellent, prophylactic. What will you give?
Prophylactically, enoxaparin.
Enoxaparin, what is the prophylactic dose of enoxaparin?
0.5 milligram per
Excellent.
kg.
Okay. What is the therapeutic dose of enoxaparin?
1 milligram per kg.
1 milligram per kg. You are right, Machan. Right. Excellent. You are. So that is the answer. Right? Okay. Will you advise the patient to walk more?
No, it can cause more. No, I don't know much about that.
No, the patient with generalized edema, can they walk?
No.
No. So that is the answer, no?
Yeah.
Yeah.
Bed
Okay.
rest.
Right. Yeah, bed rest. No, bed rest not always, but if you say like in a long case, if you say I will advise the patient to start to walk more, then the examiner will definitely ask this question. Now, patient with a generalized edema will be very difficult to walk, neither.
Yeah.
Okay, Machan. Hurry. Right. So this is the generalized management. Okay. Now, what about specific management? Specific management, you are right. You are right. Steroid. But don't tell just steroid because steroid, Machan, we are very familiar to say the steroid with the pediatric population either. Pediatric population.
Yeah.
Pediatric population usually develop this minimal change nephrotic syndrome. Minimal change nephrotic syndrome that is more sensitive to steroid, prednisolone. But in the adult population, they are developing more and various histopathological type now. So then some of them, they don't respond to the steroid. So you don't just tell steroid, depend on the histopathology. According to my consultant advice, we will start drug. That's it. Okay. Sometimes prednisolone doesn't respond. We will have to give MMF. We will have to give cyclosporine. We will have to give cyclophosphamide. We don't know. So it depends on the histopathology, and I think, Machan, we better to say it depends according to the consultant advice, and if the advice will be based on this histopathological report, we will start to drug neither. Shall we tell like that?
Yes, that's good. Yeah.
Okay, right. No, okay. So what about? So are you clear now? Are you fulfilled? Are you satisfied with the first case?
Yeah.
Okay. So, Dinindu, now can you let's progress with you with the second case. Are you okay, Machan? Hello? Would you like to do or I need your opinion only?
Machan, can you please explain why thrombosis happen?
Okay, right. I will explain. There are two reasons, right? In the nephrotic syndrome, they lose more protein, no, Machan? They lose more protein, right? So if our body loses more protein, our liver, because usually liver produces protein, liver tries to compensate that protein with another type of protein. So our liver produces more and more coagulation factors. Our liver produces more and more coagulation factor. So if there is more coagulation factor in our blood, that is more prone to develop thrombosis. There's a more chance to develop thrombosis. Are you clear, Machan?
Yes, Machan. Okay.
Okay. Right. Okay. Let's move to the next case. It takes time. Are we going very slow?
I'm okay with the speed, Majan. That's
Okay,
okay
ne?
for me. Yeah.
Okay, Hari. Dinendu, are you okay, Macha?
Okay, Banga.
Okay, right. So let's move to the second case. Can you read and progress the second case, Dinendu?
Uh,
This is just a friendly discussion, no? Don't worry.
60
Okay.
year-old diagnosed patient with diabetes mellitus, 14 years of duration, presents with generalized edema for 2 weeks of duration. He complains for the urine for past 3 months and he has a vision problem also.
Okay, right. So this is the case. The diabetic patient for 14 years of duration now has presented with this generalized edema for 2 weeks, and there's a past history of vision problem and same time through the urine. Now, what do you think, Machad? What is the most probable diagnosis?
Diabetic nephropathy.
Excellent. Why do you say this is diabetic nephropathy?
He already has developed the retinopathy.
Excellent. That is the answer. Superb. That is the answer. Okay. So, Machan, in my final, I got the same case. So, this is my case actually. The examiner's first question was this. Then I told this is diabetic nephropathy. Then sir asked why. I told the same answer because patient has developed already retinopathy. So, this is most probable diabetic nephropathy. Don't try to explain there is a proteinuria, there is a angioedema. No, because that is obvious. This is a nephrotic syndrome. Now, question is etiology. Why this is diabetic nephropathy? Not nephropathy due to SLE, not nephropathy due to malignancy, not nephropathy due to idiopathy. Why this is diabetic nephropathy? Because there is a retinopathy. That's it. Are you clear? I made action.
Yeah, Majan. Yeah, I'm clear.
Okay, right. So, Machan, okay. Now tell me, what are the investigation are you going to do?
First should confirm the diagnosis.
Excellent. Confirm the diagnosis. What will you do?
By
UPCR, neither. UFR and UPCR, neither. UFR, I will do first UFR and then I will confirm with the UPCR. All right? Okay.
Then to confirm the etiology, do random blood sugar.
No. You have to do the serum albumin and same time serum creatinine, serum albumin you have to do, no? And cholesterol level also you have to do.
Yes.
And not this point, it will be helpful to the MCQ. In the hypercholesterolemia, usually triglyceride increases. LDL also increases. HDL reduces, but predominantly triglyceride. We are talking about triglyceride. Right? Okay. So this is the same case, no? And etiology definitely HbA1. How will you treat? How will you manage this patient? Same name as general management, specific management. Here, specific management, will you give the steroid and other stuff?
No.
No need, right? No need. We have to control the glycemic control. That's it. We have to control glycemic control. Okay. Right. Let's talk about this. And this is generalized edema, no? So to reduce edema, would you like to give anything?
Can I start fusimide?
Excellent. Fusimide. You have to start fusimide. What is the problem with the fusimide? What is the electrolyte imbalance it causes?
Risk of hypokalemia.
Excellent. That causes hypokalemia. Hypokalemia. Right. Okay. So that is the reason. Have you heard in the cirrhosis also? We are giving to control ascites. We have to start spironolactone, and we have to add fusimide with a ratio 40 to 100. If you double the spironolactone into 880, you have to double the fusimide to 200. The ratio always should be maintained into 4 to 10. What is the reason? I'm talking about cirrhosis. What is the reason?
To maintain the potassium balance.
Excellent. So, because spironolactone causes hyperkalemia, fusimide causes hypokalemia, we are neutralizing. That's it. Right. Okay. So, fusimide. Okay. Right. So, fusimide. Now we are giving fusimide. Okay, now you are giving furosemide, but it doesn't respond to the furosemide, and same time now patient has developed and same time, what is the other problem with the furosemide? Here, nephrotic syndrome patient, what is the other problem with giving furosemide? They develop hypovolemia, no? Hypovolemia, because already the intravascular compartment is compromised, and you excrete, you make the patient to excrete more water, so they may develop hypovolemia. So always remember, before you start furosemide, you have to exclude hypovolemia. Okay, Machan?
Okay.
Now say patient developed hypovolemia. Now hypovolemia and patient with generalized edema. What is the drug of choice? What you are going to give? Now furosemide doesn't work much, and now patient with a generalized gross edema. What is the drug of choice? Action. Albumin, no?
Albumin.
Albumin. Neither. Albumin. And if you want, there are two types of albumin, 4.5% albumin and 20% albumin. And, right, so there are two types, and we can talk more about it, but I think we don't need. Okay, because 20% albumin, we have to be very cautious when prescribing, because it may cause pulmonary edema, right? Okay, all right, so albumin. Okay, where we stopped, right? Okay. Hari Macha, now now we are talking about diabetic nephropathy. Harida, so diabetic nephropathy now has presented with this. Okay, hello.
Yeah.
Okay, now are you going to start any drug, any other drugs in the specific management to the diabetic nephropathy?
SGLT2 inhibitor.
Excellent. SGLT2 inhibitor, right? Empagliflozins, canagliflozins, there are many drugs. Then why Machan? Why that is good drug?
It has a renal protective effect.
Excellent. It has good glycemic control effect. It has good renal protective, and another one more. Renal protective, does it protect any other organ?
Cardiac.
Excellent. Cardioprotective. What the advice you will give to the patient before starting empagliflozin? What is the thing they have to follow always, every day, before taking the drug? Any idea? You are right. Hydrate. Why hydration is important?
Risk of urinary tract infection.
Yes, they develop usually fungal infection, because they excrete more and more glucose. No, they are more prone to develop infection. So, yeah, you are right. Yes, so they have to hydrate. Okay, any other drug to control proteinuria?
AC inhibitors.
ACE inhibitor. You are right. Yes, that is the answer. Now I am going to ask a question. Now this patient with a normal tensive nerve pressure is normal. Still, do you have to start ACE inhibitor?
Yeah, it's
Yes. Right. You are right. Yes, that is the answer. Okay. So note this point. Okay. Now, if you don't treat this patient will move towards CKD. So in the management of CKD, you would have probably be taught about it. In the management of CKD, there are several principles. Number one principle, we have to stop progression. Number two is we have to treat etiological factor. Number three, we have to treat complication of CKD. The principle number one, we have to stop progression. Stop progression means we have to control proteinuria. The drug of choice is ASI inhibitor, even though the pressure is normal. Okay, ASI inhibitor, even though the pressure is normal. That is the answer. But if the patient moves towards CKD, we have to stop ASI inhibitor if the EGFR is less than 30. Right? In that case, we have to shift ASI inhibitor to prazosin, or else calcium channel blocker. But if the EGFR is high and patient is leaking protein, the drug of choice is ASI inhibitor. All right. And number two principle is, the second principle, we have to control the etiological factor. We have to treat blood pressure, we have to treat Glycemic control. So the glycemic control, the good drug of choice is SGLT inhibitor. And number 3 principle, we have to treat the complications. There are many complications in the CKD. The common complication is anemia. If you say anemia, the examiner will definitely ask the mechanism of anemia. You go and say, because there's the end of the long case now. I think someone would have already taught it. Okay. Anemia. So we have to start this EPO injection. Okay. What is the complication of EPO injection? It causes hypertension, right? It causes hypertension. Okay. And the CKD patient, they develop this electrolyte imbalance. The calcium is reduced and phosphate is increased, right? So you have to start the drug and you have to maintain phosphate level, not in the baseline, right? You have to maintain the phosphate level 2 to 9 times from the baseline. Are you clear about it?
Yeah.
Okay, right. Phosphate. And you have to start this calcium binding, calcium carbonate. So this is the management of CKD. I think we don't need to discuss it. Now, are you clear? Now you have to start ASA inhibitor and SGLT2 in this patient. Are you sure, Machan?
Yeah.
Okay, now. So let's move to the next case.
30-year-old male presents with reduced urine output and ankle edema, ankle swelling for 3 days. On examination, there is bilateral ankle edema and blood pressure is 180 over 100.
Okay,
urine,
right, that's it. So urine red blood cells is high, no?
Urine temperature, protein 2 plus and blood 3. Blood cells.
Okay, Machan. Okay, Dashi, what is the diagnosis?
This is then nephritic syndrome.
Excellent. So now they have this glomerular pathology, have several presentations. Now we are discussing one by one. Okay, this is nephritic syndrome. Now, what are the features of nephritic syndrome?
Nephritic syndrome, there is hypertension.
Excellent. Hypertension. So they usually they present with the headache, confusion, neither. Right? Okay.
Then hematuria.
Hematuria, yes. Okay, you are right. Not always macroscopic hematuria. Most of the time microscopic. Okay, you are right. Go on.
Then
oliguria, neither.
Oliguria.
Okay, oliguria. Okay, you are right. And what is last one? Edema, right? Edema, but not pronounced as in nephrotic, but still there is edema in nephritic also. Are you clear?
Yeah.
Okay, right, Macha. Now the investigation, investigation, but here the complication is much high, right? Here definitely you have to do serum creatinine, serum electrolyte. Right, okay. Machan, what is the difference between AKI in nephritic and AKI in nephrotic? What is the difference?
AKI in nephrotic was pre-renal.
Excellent. Pre-renal, yes. Here?
And AKI in nephritic syndrome, it's renal, no?
Renal, you are right. So this is renal pathology. So in the nephrotic syndrome patient, if they don't develop much urine output, we have to give fluid and we have to give furosemide, no?
Yeah.
Nephrotic. But here, if the patient do not develop much urine output, what will you do?
We have to go for replacement therapy.
No, not always, no. You have to restrict the fluid, Macha. Otherwise, they will develop overload, no?
Yeah.
Have you got this point?
Yeah.
Dinendu, have you got this point? Because here the renal pathology, no? Here the renal pathology. So here the edema is due to hydrostatic pressure. The intravascular volume is not compromised. Intravascular volume is very elevated in the nephritic syndrome. So if they develop the urine output, it means the kidney doesn't excrete anything. So you have to restrict the fluid. Are you clear?
Yes, Master.
Right. Okay. So in the management, you have to tell that, no? Okay, we will discuss the management later on. Okay. Then any special investigation are you going to do here? Definitely definitely you have to do this serum creatinine, electrolyte, and better to do this protein also. And to find out in etiology, are you going to do any other investigation? Anything else? Will you do ASOT?
ISOT.
ASOT, yeah, ASOT you have to do. But remember, okay, ASOT, you are doing ASOT, but your result is negative. Are you going to exclude post-streptococcal glomerulonephritis?
No.
No, you can't exclude. Because this ASOT is positive in 50 to 70% of patients, still in the 30% of patients, that's negative. So you can't exclude. Okay? Are you clear?
Yeah, Macha.
Right. So, and same time, you have to do the C3, C4 level and other etiology to diagnose. Right. Okay. Now, Machan, okay, in the management, now, general management and specific management, either. General and specific management, right. Okay. Now say, in the general management, it's like, it's similar as nephrotic syndrome. In your ward round, you have to measure the weight and edema, and here the blood pressure is very important. Okay, what is the drug of choice to treat blood pressure? What is the first line drug? What is the first line drug to control blood pressure? Okay, Dakshi, tell me what is the reason for hypertension here?
Because there is reduced.
Excellent. Yeah. Yes, it means elevated intravascular volume, either.
Yeah.
Increased intravascular volume is the reason for hypertension. No. Then how to reduce that hypertension? Reducing intravascular volume.
Sorry.
Reducing the intravascular volume is the first line option. So what is the drug? How will you reduce intravascular volume?
Here we cannot give. It's useless to give furosemide, no?
No, we can give furosemide, Macha. We can give. So furosemide is the first line antihypertensive drug. Are you clear?
Yeah.
Furosemide is the first line antihypertensive drug. What is the second line antihypertensive drug? What did you observe in the ward? There is a calcium channel blood test. Harida? Nifedipine or amlodipine. I clear?
Yeah.
Do you want to repeat? So in the treatment for hypertension in nephritic syndrome, diuretics is the first line drug. Okay, diuretics is the first line drug. Calcium channel blocker is a second line drug. Okay? Okay. Calcium for such as nifedipine. What about ACE inhibitor? You answer in the diabetic nephropathy, you have to start ACE inhibitor. Then what is the role of ACE inhibitor here in the nephritic syndrome?
To reduce blood pressure.
No, that is contraindication. Contraindication. You can't use. Why? Because already renal perfusion is compromised, no Machan. In the nephritic syndrome, renal perfusion is already compromised, no?
Yeah.
So if you start ACE inhibitor, it will further compromise, Machan.
Okay.
Harida, I clear, Machan?
Anyway, like because due to the reduced filtration, anyway, the RAS system will be activated. Then it will cause high blood pressure. No?
Yeah, no, Machan. No. Okay, right. I will explain. Okay, you are right. Here, RAM system will be activated. Yeah, you are right. But, Machan, usually here, the renal blood flow is maintained by renin. Right? In the AKI patient, remember this point. In the pre-renal AKI, in the AKI patient, here not pre-renal, actually this is renal. Because glomerular blood flow, we are talking about glomerular blood flow, right? That is inside kidney. So this is renal. In the AKI patient, blood flow is maintained by renin, Machan. Renin. Because renin dilate afferent arterioles and renin constrict efferent arterioles and it increases the glomerular filtration pressure. Okay, so it maintains the good EGFR in the AKI patient. If you start ASA inhibitor, the renin will be blocked. Okay, so renin will be blocked. So the EGFR will be further compromised. Are you clear?
Yeah, I got.
Okay, no, you got ne? Sure, ne?
Yeah, sure.
Okay, right. So don't start ASA inhibitor, right? Because it could be even in the MCQ, neither.
Yeah.
MCQ, right? So don't start ASA inhibitor. So these are about generalized management. Then what about antibiotic? What is the role of antibiotic in the post-streptococcal glomerular nephritis? What is the role of antibiotic? Will you start? Okay. This nephritic syndrome is not due to direct infection. This nephritic syndrome is due to immune mechanism, right? Antibody antigen complex deposition. You know, right?
Yeah.
Okay. Then still we have to start antibiotic, not for treating the nephritic syndrome. The principle behind starting the antibiotic is to eradicate the nephrogenic bacterial strain, machan. Because there are many type of this streptococcus, no, but not all streptococcus develop this nephritic syndrome. There are a few strain. They are the reason to develop this nephritic syndrome. So our duty to eradicate that kind of strain, because otherwise it will spread to another patient. Those patients also will develop this nephritic syndrome because this is a nephrogenic strain. Something called, nephrogenic strain or something. So we have to eradicate that strain. That is the principle behind starting antibiotic. So we have to start penicillin. So that starting antibiotic is not due to treating nephritic, because nephritic is not due to infection. That is due to antibody antigen complex. Then why we are starting to eradicate nephrogenic strain? Are you clear now?
Yeah.
Okay, so we have to definitely start antibiotic. Okay. Then what about any other drug, Macha? Do you want to start any other drug? There is no any specific drug, no? Because this post-streptococcal glomerular nephritis, we don't start this steroid immunocompromised other drug, right? Because it will resolve spontaneously. So we don't need to start anything. Okay. Now let's say this patient has developed shortness of breath. What could be the cause?
Due to fluid.
Okay, you are right. Fluid overload, pulmonary edema, or else sometime they may develop even heart failure either due to fluid overload. They could develop heart failure, right?
Yeah.
Due to fluid overload. Okay. Now you are treating with furosemide diuretics, but they don't develop. It doesn't respond. What will you do now?
We can give again
Albumin?
No,
but we don't have time because patient saturation is going down. We don't have time. What will you do?
Give oxygen.
Okay, you are right. Oxygen. Do we have to do any procedure to the patient? Hemodialysis, no? Okay, that is the answer what I expected. So there are several indications to dialyze. Okay? Yeah. One is pulmonary edema unless it responds to the medical management. First, always we have to try with medical management. It doesn't respond, that is an indication to dialyze. Pulmonary edema, elevated potassium, doesn't respond to the medical management. So hyperkalemia, and reduced pH. Okay, reduced pH. And there are several uremic emergencies, such as pericarditis, pleuritis, right? Pericardial effusion. So they are the indication to dialyze. Are you clear?
Yeah.
Okay, right. So that's about post-streptococcal glomerular nephritis. Let's move to the other part. Machan, do you have time? Do you want to stop or do you have to discuss? Okay,
Can come finish.
Machan, me dinindu shall we do? Will you do next case?
Number.
Is it okay?
Okay. Number 4, ne?
Okay. Yeah, number 4. Yeah. Number 4, nothing to discuss much because we have already discussed. Just read the case.
65-year-old male presents with reduced urine output, loss of appetite, nausea, and vomiting for 1 week. On examination, there is bilateral ankle edema.
Okay.
His blood pressure is in 180, 100. Ultrasound
Okay.
shows normal sized kidney with increased cortical echogenicity.
Okay. Right. Okay. So then, what is the diagnosis? What do you think, Machan? Now, patient has presented with a reduced urine output, right? Reduced urine output with the features of vomiting. Why do they develop vomiting? Vomiting, loss of appetite. What does it mean?
Constitutional symptom. Uremic syndrome.
No. Rather than that, uremic syndrome. You are right. Uremic syndrome. You are right. Uremic syndrome. Could you tell me some uremic emergency?
Uremic encephalopathy.
Yeah, you are right. Uremic encephalopathy. Yes. Uremic pericarditis. Uremic pericardial effusion. What else? Uremic pleuritis. Ne? These are the uremic emergency. Ne? Right. Okay. So here, this patient, now I say, this patient, for an example, bilateral edema, blood pressure is 180 by 100. Ne? Normal size. Okay. Right. Okay. I missed an important point here. UFR shows blood 3+. Blood 3+, protein 2+. What is the diagnosis?
Nephritic.
Nephritic syndrome. You are right. Okay, excellent. Nephritic syndrome. But usually, this post-streptococcal, if it's a post-streptococcal glomerular nephritis, they don't develop these features of end-stage kidney failure, right? For an example, post-streptococcal nephritic syndrome, they are just presenting and we are treating. They don't develop this uremic syndrome, but this patient has developed uremic syndrome. Then what do you think? Yeah, what do you think? What is the type of nephritic syndrome this is? How do you call that?
Rapidly progressive.
Anything start with R? Rapidly? Yeah, that is the answer. Right. Rapidly progressive glomerular nephritis. Okay? But don't worry, you won't get this case in the long case, but you can get it in the MCQ. Neither. Now, I clear. This is how the case they will present the case. Right? So, rapidly progressive glomerular nephritis mean usually that is a nephritic syndrome, but they very, very rapidly progress. It means they develop acute renal failure, end-stage renal failure, and serum creatinine is very much elevated, right? And there are electrolyte imbalances, pulmonary edema, uremic features, right? So, sometime you may have to dialysis the patient. That is rapidly progressive glomerular nephritis. If you do biopsy, what will you observe in the RPGM? Have you heard anything about crescentic shape? Crescent. Have you heard it? Yes, crescent formation. You will observe crescent formation. Okay. So it will be useful in your MCQ. Okay, that's it, ne? Okay. Yeah. Right. Okay, that's it. Next case also we have already discussed. Next, the fifth question. I have taken this question from our final pass paper. Could you read the question and answer it?
Fifth one, no?
Yeah, fifth one.
The 35-year-old male presents with bilateral ankle swelling and the routine medical check 60 blood pressure 60 over 105 millimeters to mercury, pulse rate 78, UFR shows protein 2 plus, serum creatinine increase, blood urea increase, sodium normal, potassium normal, GFR 40, ultrasound shows increased cortical echogenicity, normal size kidney, what will be the best drug?
Okay, what is the answer?
So this is electrolytes are
Here the
normal.
etiology is not clear. Etiology, we don't know about etiology, but definitely this is a CKD.
CKD patient.
Because GFR is 40 and same time there's a protein leakage also and pressure also high. Then what is the principle of treating CKD? I have already mentioned. Tell me the three principle.
First, we have to give
No, principle. Stop progression.
Prevent complications.
Prevent complication and treating complication and treating the cause, etiology.
Yeah.
There are three principles. Okay. So here, Machan, is it possible to stop progression in this patient?
No.
Why?
Already.
No, EGFR is still 40, no?
40.
That's not end stage. So still we can prevent, no?
Yeah, so renoprotective.
Yeah, you are right. Go.
So we can use calcium channel blocker.
No, calcium channel blocker can be given, but is it renal protective calcium channel blocker? No, right? No, we have discussed it earlier, right? Just before. What is the renal protective drug to prevent proteinuria?
Is AC inhibitors.
ASA inhibitor. Okay. Yeah, you are right. ASA inhibitor. Can we give ASA inhibitor to this patient?
We can give.
Yes, we can give. Right? Because EGFR is 40. Still we can prevent. No, this is not end stage. But if it's end stage, shall we give? Can we give? No, we can't give. So this is not end stage. So then what is the drug of choice? Captopril, no? Captopril. Okay, that's it. Why do you think much? Because you answered, no? Previous question, you are the one who answered. Okay, so this is MCQ, right? Okay, I will ask one question. How will you differentiate AKI and CKD?
AKI usually occurs after we can in our ultrasound the CKD kidneys shrunken most of the time.
Yeah. Okay, you are right. Okay, you are right. So that is the answer. Okay, Machan, if the examiners ask how will you differentiate AKI and CKD, don't tell this electrolyte imbalance and this hemoglobin. Don't tell that, okay? Because usually hemoglobin is reduced in CKD. That is normal in AKI. But still, there may be low hemoglobin in AKI also, right?
Okay.
So we can't differentiate. And electrolyte imbalance also, we can differentiate. Can differentiate, but that's not sensitive. But what are the very sensitive tests to differentiate AK and CKD? One is past medical report. In the past medical report, for an example, the past medical report, serum creatinine level was normal. But now that is suddenly elevated. What is that? It can't be CKD.
Yeah.
That is AKI. So we have to know about past medical report. That is first one. Other one is ultrasound scan. In the AKI, the kidney size is normal usually. But in CKD, what about kidney size in CKD? Shrunken, no? Shrunken. And increase, and there is a poorly differentiated cortical, this cortical medullary demarcation is poorly differentiated, right? And okay, now I am going to ask a question. In CKD, could kidney size be normal?
Diabetic. Diabetic.
Yeah, right. You are right. That is the answer. Okay, not just point much. And there are three examples where In the CKD, kidney size is normal. Number 1 is diabetic. Number 2 is CKD due to amyloidosis. Number 3, CKD due to HIV. Okay? Are you clear?
Yeah, Master. Yeah.
Okay. So that is answer. Shall we move to the next question?
Okay.
Okay, last question. Huh? Right. Who will be answering to that question?
I'll tell. 20-year-old woman presented generalized edema and protein urine. Blood investigation shows positive ANA and DSDNA.
Okay. What is the diagnosis?
SLE.
SLE, right. Okay, note this point. SLE has various presentation, but usually SLE has 2 main presentation. Unfortunately, it will be given to the exam. The 2 main presentation, one is lupus nephritis. Other one is hematological problem. For an example, they may present with ITP, idiopathic thrombocytopenic purpura, or hemolysis, right? So SLE has various presentation, but 2 main presentation is lupus nephritis and hematological presentation. Right. In the lupus nephritis, we have already discussed important points, the management, everything. I will be answering several. I will be telling several important points. Please note. Definitely, we have to do renal biopsy. In the lupus nephritis, definitely we have to do renal biopsy. Why that is important? Why renal biopsy is important is because there are 6 classes. Lupus nephritis, there are 6 classes. Class 1, 2, 3, 4, 5, 6. Depending on the classes, our treatment will verify. Okay? Right. And 3 and 4 classes should be aggressively treated. Not the point. It was our final MCQ also in our batch. Right. There are 6 classes. Class 3 and class 4 should be aggressively treated because still we can prevent, and the class 3 and 4, they are proliferating. It should be treated. If we treat, we can prevent. But no point of treating class 6 aggressively because that is already on CKD. That already has progressed to the CKD. So aggressive treatment won't work. But class 3 and class 4 should be treated. Okay, then what is the treatment? You have to admit the patient. You have to start cyclophosphamide. It means the flare-up now. Patient has presented in the flare-up. SLE, there's a flare-up phase and then remission, right? Now patient in the flare-up phase. Now you have to start cyclophosphamide. Cyclophosphamide, you have to start 6 cycles once per 2 weeks. One cycle. So patient has to be admitted once in 2 weeks. We have to totally give 6 cycles. Okay? Right. And methylprednisolone pulse therapy, not oral prednisolone. This is methylprednisolone pulse therapy. I am talking about class 3 and 4. Okay. Now, examiner may ask then what is the side effect? What is the problem by treating with cyclophosphamide? They may develop hemorrhagic cystitis. But that is hemorrhagic. They will pass hematuria. How will you prevent hemorrhagic cystitis? We have to give. Yes, Machan?
Ask them to hydrate well.
Excellent. Hydrate well. And we have to give in the, so that's why we have to give it in the daytime because they have to frequently pass urine. Okay, you are right. Anything else?
Mesna, we can do Mesna.
You have to add Mesna, but excellent. You are right. You have to add Mesna, right? So that is how you have to, you can prevent this hemorrhagic cystitis. So that is number 1 side effect. Number 2 side effect is cytopenia, right? Because the bone marrow problem, cytopenia. But cytopenia, examiner may ask, okay, when do they develop cytopenia? Is it immediate reaction? No, answer is no.
Second week.
Yes, usually they develop in the second week, after 10 days. Are you there? Right? Now you are treating with the 6 cycle of cyclophosphamide. Now patient came to the remission and then you have to start MMF for 18 months. Okay?
Yeah.
Right. So examiner may ask, before starting cyclophosphamide, are you going to do anything? Yes. Because cyclophosphamide may affect their sexual function. It may cause premature ovarian failure, right? So we have to preserve the ovum, and we have to preserve it in the bag. Okay, so we can do that. So that's about, that is the management of lupus nephritis. Okay.
Okay.
So this is a specific management. Other management we have already discussed, no?
Yeah. General management.
Okay. So what about Machan? Is it okay? Is it enough? Are you satisfied?
Yeah, Machan. Yeah. It's good that
Okay.
everything we have to categorize into general management and specific management. It's
Yeah. Okay. Yes, that's it. No, I think now you can do anything. You can do essay, MCQ, everything. No, you can answer to the longest also.
Yeah.
Are you going to ask anything? Do you want to ask anything?
Yeah, come on, one night shape.
On that.
On the next shape, ne?
Yeah.
Okay, then shall I stop?
Thank you very much. Thank you very much.
Okay. Right. Okay. Bye.
Thank you.
Bye.